Okay, so I think we can probably begin the session. So welcome back to everyone who joined last week, and for those of you new this week, welcome to our second Rural and Remote Nursing and Midwifery series on Why Rural this week. So for those of you who don't know me, my name is Pip and I'm the program lead for the New South Wales Rural Doctors Network Future Workforce team. I also come from a rural and remote nursing background and am particularly passionate about rural and remote nursing, but also rural and remote health in general. So it's with great pleasure to be able to organise this event for you guys and be here. So before we begin, I would like to acknowledge and pay respect to the traditional custodians of all the lands in which we are meeting on today, and pay respect to elders past, present and emerging. With me here again tonight, I have Chris Russell, the Future Workforce Manager, who was here last week, and I'll just hand over to him to say a quick hello.
Thanks, Pip. Thanks, everyone. And I will definitely make this one a quick hello. I'm assuming most people were here last week. If you weren't, my name is Chris, as Pip pointed out. I'm Future Workforce Manager. You know, my job is to help you guys go work in a rural or regional or remote area if that's what you're interested in. So hopefully I'll see you over the course of your career at some point and help you at some point as well. Looking forward to tonight. It should be great. Last week we had a brilliant session on interviewing and resumes and whatnot, and tonight we get into more of the sort of the personal side of things and hear a bit more about some of the experiences. So I'm really looking forward to it. It should be great. Thanks, Pip.
Cool, thank you. I've lost my mouse. Did it come back? Okay. All right, so let's see if we can. We're just going to hear quickly from the CEO of RDN, who wants to say a quick hello.
Hi everybody, it's Richard Colbrand, the Chief Executive of the New South Wales Rural Doctors Network. Thanks so much for joining us for this second instalment of our four-part series for nursing and midwifery. And we're really pleased to bring this to you through our digital venue. And we've put a lot of effort in the last few months in trying to ensure that all of our training and upskilling work can continue through the isolation and social restrictions of COVID-19. Before we start today, I'd just like to acknowledge the traditional lands across all of Australia from which we meet today and pay respects to elders past, present and emerging, and put a big call out to our Indigenous friends and colleagues who are participating in this series. As I said, today is the second of four instalments that we've been producing for the Nursing and Midwifery series. And today we've got a great panel, some great friends of all of us who work in rural health. This session today is more about the journey, talking about what nursing and midwifery rurally looks like, some tips and tricks, some hacks, and we really hope you get to enjoy this conversation. Make sure that you use the chat functions that are available here. There's some great people online who are very willing to help and provide support and advice from their experiences. Plus also don't forget the team at RDN are available to help you. If you've got any questions, we've got our grants and Go Rural opportunities for our nurses and midwives, and I'd love to be able to help you in any way we can, so make sure you get in touch. So thanks very much for joining us. Thank you to our panellists, and I look forward to talking to you again soon. Cheers. Hi everybody.
Okay, so as many of you may have read when you were registering for tonight, this session will really lead on nicely from last week, and we're hearing from a number of speakers from very diverse and interesting backgrounds across both nursing and midwifery, and we'll be essentially travelling all throughout New South Wales, Australia and beyond. We're really excited to be able to have a mix of nurses, midwives and some dual registered clinicians here tonight. And first up we have Leonie Parker. So Leonie is a nurse practitioner who is passionate about and has dedicated herself to women's health throughout most of her career. Leonie works in Western New South Wales providing gynecological and women's health services for small rural communities with high Aboriginal populations. Much of Leonie's work is with marginalised populations ensuring access to healthcare services such as preventative healthcare, contraception, cervical screening and women's health in general are delivered. Leonie's breadth of experience and expertise is inspirational. We're very excited to have her on board, and I'm beyond delighted to introduce her to you all tonight. Thank you, Leonie.
Can you hear me now? Okay, great.
Got you.
Okay. All right. Thank you very much, Pip, for inviting me to speak tonight. It's probably one of my favourite subjects. My career's been exciting, and it's just really, I've had so many opportunities and I've been so lucky, but a lot of that is to do with my rural upbringing, my rural education, and my passion for my rural communities. So it's kind of, you know, one's fed into the next. I grew up in a small country town of 3,000 people in the middle of New South Wales, a little town called Condobolin, the home of Shannon Knoll, a few other famous people from that little town as well. I won't bore you with that at the moment, but so I did my high school, all my schooling in Condobolin, and went on to the Royal Alexandra Hospital for Children in the early 80s to do my registered nursing training in the old-fashioned way in the hospital setting, which was very frightening for a small country town girl, going to Sydney, being away from family for 3 years, that kind of thing, to do the training. But I always look back on that training, and I still use a lot of the knowledge that I gained from that training in my work today. I came home for a while after I registered as a registered nurse. I came home to Condobolin. I worked in community, and I worked in the general ward of the small district hospital in those days. In those days, it was a 20-something bed hospital, ranging from the emergency department to birthing of babies, community nursing, general medical and surgical, in that small little town hospital. Back in those days, that rural hospital would often have theatre lists of paediatric tonsillectomies, adenoidectomies, ranging up to even mastectomies, hysterectomies, those kinds of things on a really regular basis. Small country hospitals have changed a lot in the last 30-odd years. We don't seem to have the GP expertise that we did many years ago, and of course all of that surgical expertise is not found in those small hospitals anymore, so it sort of cuts down a little bit of the variation on what you can do, but it's still exciting nonetheless. From my graduation in Is that okay?
That's good, thank you.
Okay, sorry. Okay. All right. So from my graduating as a registered nurse, I was really keen to go back and do some work in midwifery and be trained as a midwife, which I did. I worked on in some busy maternity hospitals in Sydney. I did my training at St Margaret's in Darlinghurst, which is extremely busy hospital back in those days for maternity cases. Really great grounding for a midwife. And long story short, after I had my daughter, I really needed to get back to the country and give her a country upbringing. I felt safe there as a mother bringing a child up. So that brought me back to Condobolin, where education was thrown at me. If you were keen to learn more and do more, then education possibilities were just thrown at you, and they still are today. There's lots of emphasis on education. With all the online stuff available today, it's really easy to access. There's multiple scholarships, as Richard spoke about earlier. The Rural Doctors Network are extremely supportive of anybody who wants to show some initiative and to extend their scope of practice. So I worked in Condobolin in a number of different areas as a ward nurse, did some work in the emergency department and that kind of thing. And then we had a really bad GP crisis in 2004 where all of our GPs just left town. So we had women that were driving 2 hours to and 2 hours from normal GP appointments to access contraceptive pill scripts. And I don't know if any of you have used country roads, but sometimes, you know, they can be quite dangerous. And it's, you know, it's really, you know, it's a backward step for women to have to travel, or anybody have to travel so far out of their community to access something really basic. So I decided then that, you know, this is my community. I wanted to serve my community, and I wanted to do something a little bit more as a nurse to be able to give more access to women in particular around services. So I did my master's and became a nurse practitioner. And I've been working since 2007 in a women's health nurse practitioner role, which has been extremely rewarding, extremely frustrating at times, but more often than not rewarding. And I've been offered so many opportunities because of it. My area of expertise, obviously, women's health, basic women's health, cervical screening, examination of anything that comes my way as far as women goes. It can be looking after young girls that are having problems with their periods, to contraception, antenatal, postnatal, engaging with Aboriginal health workers and providing services shoulder to shoulder, and engaging more Aboriginal women into these services for better outcomes for them and their children and generations to come, really. I've been really lucky to, the last probably 8 years, or 8 years ago, I was offered the opportunity in partnership with the Rural Doctors Network to establish the first nurse-led colposcopy service in Australia. In the UK and the US, the nurse practitioners have been providing colposcopy services for around 30 years, and quite successfully. All of the research says that nurse practitioners providing colposcopy, which is the examination of the cervix under magnification and illumination. It's the examination, for those of you that don't know, it's the examination that happens usually by a gynecologist after you've had an abnormal pap smear. So to be trained in that area was really exciting. So I was offered the opportunity because the GP service that was established at the Orange Aboriginal Medical Service was no longer. They had the equipment, but they couldn't find anybody to provide the service. So they approached me, being a rural nurse practitioner in women's health. I did some study with and under the mentorship of Dr. Michael Campion from the Royal Hospital for Women in Sydney, and I travelled to the United States, New Zealand, Canada on a study tour that was funded by the Judith Mepham Scholarship, which is a fairly prestigious scholarship offered by New South Wales Health. And from there, we've now been offering our colposcopy service in partnership with the Rural Doctors Network, Orange Aboriginal Medical Service, and the Royal Hospital for Women, and of course our local health district. For 8 years successfully, we've been running a clinic every month that spans 1 to 2 days, depending on the demand. We've done over 500 colposcopies now, with well over 1,000 referrals. So we're seeing mainly Aboriginal women, or that's our target group, and we are actually providing cancer prevention service, which is fantastic. We've won a number of awards for that service, and we're well recognised, not just in Australia, but over in the United States and the UK as well. The thing about rural health is the passion of the people, being able to work alongside some really exciting people to be able to expand your scope of practice into areas that you never thought may have existed. You know, the beautiful surroundings of working and living in rural communities, the passion of the actual community and the engagement socially with the staff. You're held in high esteem in the rural communities as a health worker, especially as a rural nurse. And I told you, Pip, I could go on for a long time. So am I going over?
No, it's great. It's really good.
Okay. So opportunities are thrown at you for your education, and there's really no barriers to education. And the more that you soak up, the more that you can do. And the more that you can do for the community, the better you feel about your work. You'll get to know your patients and the community members way more than you ever would in a regional or in a metropolitan setting. And that in itself is rewarding, because those people, your patients, actually become your friends. It can be a little bit difficult when one of your community members has a terminal illness, but I think that you can actually give more by knowing them a little bit more, and that again gives you great feedback and a great feeling as a community caregiver. I wouldn't be anywhere else. I love my work. I can travel to smaller communities and give more, and it's just been the most amazing, rewarding career. It's just really been fantastic. And if I had my time over again, I wouldn't change a thing. It's been amazing. So thanks, Pip. Sorry to go on a bit, but if anybody wants to contact me and ask me any questions about how to access different things, or any support at all, or any questions you might have, I'm more than happy to answer those through my email, I think. And I think probably Pip will put that up later.
Yeah, sure. Oh, thank you, Leonie. That was amazing. Very, very humble and very inspirational. I'll invite people now to start asking questions. If you could please use the chat function, that would be the preference. The Q&A is there also, but there's been a few faults of that. So we'll try and keep with the chat. And we'll give a few moments for questions, and then we'll move on to our next speaker. So if anyone has anything they want to ask at the moment, feel free to just pop it in the chat.
I'll ask a question if that's all right. I'll indulge as soon as I can come
Go for it.
Mute. That was amazing, Leonie. Your career's like incredible. So many opportunities and so many amazing things that you've done and you do. I get asked quite a lot by nursing students about when the best time to go rural might be. So, like, should they be trying to get, seek out placement opportunities through university? I'm assuming they should, but then should they look to try and go straight out of university to a rural location? What would the benefits be of doing that versus maybe should they stay in the city and try and get some skills up before they go?
That's a fantastic question, Chris, and it's often something that I talk to the students when they come out to our hospital on placement. I think it's really beneficial for them to come out during their university time, get a little bit of a taste for the rural side of things, but I think it's also really important to just get some really good grounding in some of the bigger hospitals, to get some confidence and some of that you know, especially the emergency interaction, because when you're a rural registered nurse, you're expected to work in a lot of times, especially in the smaller communities, you're expected to work a little bit in the emergency department. So you need to have that confidence behind you, and a few experience in some, you know, some trauma and that kind of thing. I think that would really stand you in good stead. But you will learn a lot on the job. You'll learn more about the culture in the EDs and things like that, and the culture of the people that you're looking after as well. There's some really good support out there. But yeah, that's what I would do. I would ask. I would have a little bit more time in the city, maybe 1 or 2 years post-grad, and then go rural. You have a lot more to offer to you in that situation.
Awesome, thank you.
Yeah,
great.
Fantastic. Okay, we have a question here from Matt. I think he wants to email you and elaborate a little more, but I think he's sort of asking about when you're triaging a patient, how is it that you can make a quick assessment and know what to do in such a short period of time, or in the time that you may see a woman in a vulnerable situation?
Okay. In my working community, I don't have to triage people in the small time frame as you would in the ED. I haven't worked in the emergency department now for quite a while, but my work in the community, I can actually take my time, and the beauty of that is if I have a woman that is in crisis or trauma, or presents with some symptoms where there may be a cancer involved or something like that, then I can spend an hour with that woman. I can reschedule pretty quickly. My community knows me. They know that I'm not doing this because for no reason, if I need to reschedule, which isn't very often. But I know that I can actually spend more time than actually 15 minutes or a 5-minute quick consult or something. If somebody needs it, I can provide a bit more time for them.
Fantastic.
Yeah.
Okay, cool. We have another question here from one of our panelists. Chelsea, do you want to ask that yourself and take off mute?
Sure, no worries. Hello, and thank you, Leonie. That was really interesting. I'm wondering, are you the only nurse practitioner that you know of who provides colposcopy services in New South Wales or in Australia, perhaps? And the other question I had was, can you provide these services throughout your LHD, or are you tied to just one facility?
Okay. Okay, so when I started, I was the first nurse colposcopist as a nurse practitioner in Australia, and I was the first nurse providing a nurse-led clinic. There have been other nurses that work in private gynae clinics that actually do colposcopy, but they didn't have the autonomy to be able to provide all of the pathology and make the clinical decisions, that kind of thing themselves, as far as I understand. There's a nurse practitioner now in Queensland that works out of a private gynae clinic, and one in Melbourne that I know of. And there's a couple of nurses that have trained in the UK that could be providing colposcopy, but as I understand, they're not nurse practitioners, so it's difficult for them to be able to be totally independent. As a nurse practitioner, you might know, Chelsea, if you work in the public health system, you're restricted because you can't use the Medicare system. Are you aware of that?
I have heard little bits and pieces about it, but yeah.
Yeah. So in public health, you can't have a provider number for Medicare for your patients, and so there has to be a number of workarounds to be able to provide referral for pathology, which is really important for colposcopy because you're taking biopsies of the cervix and that kind of thing. So I work with Dr. Michael Campion, who out of Orange Aboriginal Medical Service, and it can be quite frustrating because being employed in public health has those boundaries. So if you're in private health, if you're a private practitioner, even as a women's health nurse practitioner, you can access Medicare for your patients as long as you have access to all the fabulous clinical examination tools and that kind of thing, like a colposcope and those kinds of things. Then in private practice, you can have all of those at your fingertips. The ability to refer, the ability to order tests, all come under the Medicare for you if you're in private practice. So that's where my next part goes, and that's my next part of the story is for my people to provide a private practice colposcopy service, just to make it easier and less clunky. So we're sort of working on that at the moment. Sorry, that was a very long-winded explanation, but it's quite involved once you get into it. It's quite involved.
Thank you.
Thanks, Chelsea.
Thanks so much. That's great. We have a couple more questions, but I might leave one to the Q&A at the end, and the other one I think our next speaker might address. So before we move on, I'll just remind everyone this is being recorded. So if you want to go back through it, we'll direct you there at the end, and you'll be able to access this again in case you have to leave. So our next speaker is Maisha, a proud Indigenous nurse and midwife. Originally from Coffs Harbour, Maisha has spent time working in Dubbo and in outreach roles in Burke and Brewarrina in northwest New South Wales. Maisha is passionate about her communities and committed to providing culturally safe, patient-centred care to perinatal women. Maisha is a member of Katsanam and is presenting here this evening on their behalf. So it's without further ado, I introduce Maisha to you all this evening.
Hey everyone, can you hear me all right?
Yep, got you.
Perfect. So first of all, I just want to acknowledge the traditional owners of the land that we're meeting on today, and pay my respects to both past, present and emerging future leaders. So my journey to become a nurse and a midwife was a bit out of the, not out of the ordinary, but so I grew up in Coffs Harbour. All my family is from there. Was born on Bundjalung land. My mob's from Yaegl and Gumbaynggirr. And I did my high school in Coffs and was the first person in my family to finish high school, and started working as an Aboriginal health worker at my local AMS for I think it was about 3 years all up. And I worked in like smoking cessation and healthy lifestyles. I knew from an early age in high school that I wanted to get into healthcare. I wasn't sure what road I wanted to go down, but I knew that I wanted to get into healthcare because I had a lot of people in my family that were really close to me become unwell, and just the mistreatment from the doctors and like the hospital system and all that, like it just was really frustrating. I mean, today it still is really frustrating to me, but that was a really driving passion for me. So I knew that I wanted to make a difference somewhere there. I just wasn't sure where my journey would go. But I started working as an Aboriginal health worker, and I just by chance, I wasn't really sure if I wanted to go to uni. No one in my family had ever been to uni. So I applied, and I didn't think I'd get in. I just had no confidence in myself, I think. And it was scary too, because, you know, I had no one else to go off basically. So I applied and I got into nursing at Southern Cross University in Coffs, and I wasn't going to go. Basically, I sat on the letter that they sent me being like, yeah, you're in and that. And I was like, oh, I don't know if I can do it. And it was, I remember it really clearly. There was someone that was working at Katsanam. I'd sort of wrote a letter to them and said, hey, like, I'm thinking about doing this, but I'm not too sure what, like, if I could, basically. Anyway, I remember finishing work one day. I got in my car and I had a missed call from someone, and I rang them back, and it was this woman from Katsanam, and she sat on the phone for like an hour with me, and I'm sitting out the front of my work, and she's like just yarning with me, going like, and she just believed in me. She was like, you know, you can do this, like, and basically that day like changed my projection of where I was going, because I was like, okay, someone believes in me, like maybe I can do it. So throughout my degree, I've stayed in Coffs Harbour pretty much, and I continued working full-time because I was also caring for my mum and my brother. I'm oldest of 5 as well, so I was caring for my brothers and sister at the time. So I stayed, it was really important for me to stay in my home community during that time. And I don't think I would have been able to make it through if I had to have moved at the time. But yeah, so I continued working, and I did my placements, and I was supported by Katsanam, and was also on the Aboriginal cadetship, which allowed me to have extra placements in the hospital and also work closely with the Aboriginal liaison officers in the hospital and that sort of thing, which was really supportive for me, because I did struggle throughout my nursing degree, and also just in general, like since becoming a nurse and working in the healthcare system, I have struggled with different racism incidents, but I always had like Katsanam there to back me, basically. So I did my final placement in Mount Isa. I was there for about 4 weeks, and I always knew that I wanted to go rural. I just wasn't too sure if I wanted to move away from home yet. It was still very young. I just had a really close connection to country and didn't want to move away from my people at that stage. But I had so much fun in that 4 weeks in Mount Isa, and just seeing the different lifestyle out there really sort of sparked something in me to go, you know what, like we can put this on hold for now, but we're going to do something similar to that. So I continued to work at Coffs Hospital for a couple of years, and again, something just happened. I applied for the mid-start program at Coffs, and I mean, I don't know, maybe I don't have much confidence myself when it comes to applying stuff, but I was like, I'll just apply for it, I probably won't get it. Anyway, so got enrolled into the mid-start program, and I was the only Indigenous midwife in Coffs at the time, and like student training there. And that was really tricky. I found that really difficult with just having a culturally safe place to practice, basically. It was fantastic from a point of view that I was able to work with my community and be able to advocate for my community, but it was that burnout factor for me was a really big thing. So I finished my degree, and I thought, you know what, now's the time. I'm gonna apply for something different and go out west and give that a go. So I applied for a job out in Dubbo, and I moved to Dubbo. I moved there in like the week that it was like 46 degrees, and I was like, what am I doing, coastal girl moving here? But it was such a great experience. I worked in Dubbo Hospital for a couple of months before applying for a job in the outreach position for Burke and Brewarrina. And that's, yeah, basically from then I would like fly with like RFDS, or drive out to Burke and deliver the antenatal and postnatal clinics and see the women out there, which was just absolutely amazing. It was such a great experience, and able to work so closely with the women from there, but also because I still lived in Dubbo, so I would come back, and the women, there's no birthing facility out in Burke or Brewarrina. So women have to travel about 4 hours to be able to birth at Dubbo Hospital. And so sometimes women would be flown down in the middle of the night without their families, or, you know, their families couldn't afford to come down and stay for the 2 weeks that they've got to be down before their due date. So it was really great opportunity to go in and check in on the women each day on the ward and just make sure everything was okay and try and, you know, support them as much as I could. Those women became like family to me. I was like always going in and checking with them, like, is everything okay? Like, so yeah, it was really great. I finished up in Burke and Dubbo in I think January this year, and I've actually transitioned to or I'm actually in medicine now, studying to become a doctor, and that's purely because of those frustrations of like getting into I just felt like I needed to do more for my, not more, but I was getting really frustrated with like and this is probably just more from a personal point of view, like, you know, my mum was admitted to hospital and she just had a really poor doctor that didn't treat her right, and she discharged it against medical advice, and she wouldn't even take my advice from me. Like, I mean, I'm the daughter, but yeah, so it was things like that I kept coming up against, and I was like, I love nursing and I love midwifery, but I just felt like I wanted to go somewhere else, and I was coming up against things like, you know, the women being mistreated by their GPs and different things like that. So I thought maybe, and just not that like cultural sensitivity and like culturally safe space. So I decided to make the transition, and that, so yeah, that's kind of where I'm up to in my space. It definitely hasn't been easy, but it's been an experience and I wouldn't change it for the world. And yeah, like Leonie said, like the lifestyle living out in Dubbo and also like when I was working in Burke is absolutely amazing. Like I made so many great friends and people that I consider family now. Like I moved out there not knowing many people, and I moved away having a whole new family that lives out in Dubbo, you know. So I was like, I mean, coming from the coast and coming from somewhere that was like fairly like regional, I was a little bit worried about going out there, and it was like, well, what about, you know, what about if nobody likes me in my workplace, or, you know, what about if I don't have the skills to be able to you know, deliver what I like, the care that needs to be delivered and that. But there were times where it was scary because, you know, sometimes there's, you know, a lot of new grads on the ward, and it's people are looking at you going, what do you do? And you're like, what are you looking at me for? But yeah, it's generally really well supported, and like Leonie said, there was always opportunities to upskill, and there was always people around to have a yarn to, and that cared about how you were going, which I absolutely loved. So yeah, that's my story.
That's just amazing. Thank you so much for sharing all of that. And I think not only myself, but everyone has been really inspired by what you've told us and your experiences and how far you've come. It's just incredible. We have a few questions.
Cool.
Steph actually asked this before, but was wondering if, from your experience, do you know how difficult it is to enter Aboriginal health not being Indigenous?
It's not difficult. It's just coming from a place of being culturally aware of like of that community and the people in that community as well, and just understanding. I think a big thing too is understanding like transgenerational trauma as well, and because, you know, that a lot has happened in these communities, not just, you know, New South Wales rural area, but everywhere, and just acknowledging that and why things are the way that they are, and that and just being respectful to and like, you know, most of the time you'll be supported with an Aboriginal health worker. Like when I worked in Burke and Brewarrina, I had Aboriginal health workers work with me, and like they're the absolute like bread and butter of that community. Like, you know, that they know that community in and out. Like we used to jump in the bus and go find people like for their appointments, and, you know, like they knew exactly where that person would be, and that. So, or if, you know, there was issues in the community, they would know what was going on and stuff like that. So yeah, I think just being aware and culturally respectful, and, you know, in your job they will do cultural immersion days and different things like that, but try and do a bit of your own reading as well if you can.
Yeah, I think that's amazing advice, you know, being a non-Indigenous woman as well. I think it's, yeah, really interesting area. Okay, well, I actually think everybody is absolutely in awe at the moment. So what we might do is we might move on to our next speaker, and if people have questions as we go, feel free to keep posting them in. Okay. Okay, so our next speaker is Mitchell. So Mitch is a registered nurse with a very diverse and exciting range of experiences under his belt. Mitch spent the majority of his first several years following uni in Broken Hill, working in remote sites including Ivanhoe and in the ICU and ED, before heading off on a number of locum adventures. Mitch's work has also taken him abroad to Afghanistan and Saudi Arabia, respectively, in extremely interesting and challenging roles. Following these adventures, Mitch recently returned to Broken Hill and has accepted the clinical nurse specialist role in ICU at the base hospital. So it's with great pleasure that I invite Mitch to come and say hello to you all.
Well, some pretty big shoes to fill after the two ladies before me. Like Maisha, I'm also from Coffs Harbour. Was a pretty unlikely candidate to end up out west. I also studied at Southern Cross in Coffs Harbour. On one of those placements, I took a month and came out to Broken Hill for a bit of a change of pace and to see how they do it out west, and really loved my time out here. So for my new grad scheme 2015 that I applied for, I applied out here and was fortunate enough to get a position. And again, similar experience. I drove out here the end of January on a 47-degree day or something disgusting, and was thinking, what have I done? Moving from beautiful Coffs Harbour to come out here, but thankfully I did. So out here at the time, they, for the new graduate scheme, you'd go through 3 rotations. So for my rotations, I went through a subacute rehab unit. I did a remote stint in a small little town of Ivanhoe with a population of about 90 people, and then finished up on the surgical ward in Broken Hill. Each of these rotations out here, they put you through for the scheme, kind of offer a whole host of different opportunities you just never get on the coast. So studying the rehab unit's a bit of a slower pace, I guess, compared to a lot of other areas of nursing, but really got to master your ADLs and just your basic nursing cares, which was really good. Onto Ivanhoe was probably the biggest culture shock, I guess. As I said, very small town. There's no doctors there, so a lot of the time you'll be doing primary healthcare work, but you're also their emergency services. We were their ambulance. It was only myself and one other registered nurse and an Aboriginal health worker as well. So between the 3 of us, we kind of had to juggle whatever came through the door. Through that, you really get to perfect your primary health work and your primary assessments. And that was, I guess, my first taste of ED nursing, which I started to enjoy. They also, as Leonie was saying before, really throw education at you. So I was able to do my FLEC and PEC courses, which were at the time a frontline emergency care course and principles of emergency care course, which kind of enabled you to have a broader scope of practice while working in remote areas. Again, that kind of pushed that higher level of care, which I enjoyed out here, that you just don't have the opportunity to do back on the coast. Coming back to Broken Hill, finished off my new graduate program in the surgical ward before applying for a transition to specialty program for my second and third years. Again, was quite fortunate, picked up that scheme. For that, they offer like a 6-month transition through ED and ICU for the first year with some further training in both of those. And then for the second year of the program, you can decide which you'd like to spend the rest of your time in. By that stage, I'd kind of fallen for ED, that nice fast-paced nursing that I'm sure you'll all get to experience if you haven't already. And really enjoyed that. You really get to see they're a different breed out here. They're tough as nails, like salt-of-the-earth people. So they'll come in with, oh yeah, I broke my leg a week ago, but I had to drive my truck and finish mustering and everything, which you just don't get back home. And really, really enjoy that side of it out here. Yeah, as I said, just salt-of-the-earth people. So I was quite fortunate as well. I did my graduate certificate in emergency nursing out here because they do really push education to progress you through your career. Through that, like by the end of the new grad year, you're doing in-charge shifts on the surgical ward, and you are getting kind of pushed to a higher level, which the support was there, so we really enjoyed and took it with both hands while I could. 3 years, so originally I moved here for the 1 year just for my new grad and planned on running back to the coast, but next minute I've been here for 3 years. Thought I'd have a bit of a change of pace and a change of scenery, and started to do some locum work and worked in Goulburn Emergency for about 5 months. Thought I'd push it a little bit further and worked up in a correctional facility in Queensland for about half a year as well, which was pretty eye-opening. I'd never worked in corrections before and thought it'd be a lot easier than it was. So it was pretty interesting in that regard, and you really do have to utilise a lot of the skills I learnt through ED here, and especially down in Ivanhoe. Whilst still being quite close to a large city, you're very isolated in the fact that there's a lot of gates to get through and a lot of security to get through if you do need an extra set of hands. So we didn't have any doctors on site there, and if there was any drama, an ambulance, despite only being 5 k's down the road, would take about an hour to get to you by the time they got through all the security. So it was really good having that kind of earlier experience in the remote sites to increase your clinical judgment and clinical skills when you need it, which was nice. From there, I got a little bit more adventurous and went over to Saudi Arabia for an agency program for about 3 months as well. They really pushed their healthcare to the limits over there. So the hospital was ridiculous. It's about 2,000 beds. The ED alone was 110 beds, which is bigger than the entire Broken Hill Hospital that I work in again now. So that was a bit of a shock, but an amazing experience. They've got all the education and all the money to throw at their new Gucci technology over there. So you get to play with all the fancy equipment, which was a great learning experience. And a great cultural experience as well, just to see how different nations do their emergency work. Again, after that, I thought I'd give it another go overseas, and I ended up picking up 2 3-month rotations through Afghanistan. For there, I was based on a NATO military base in Kabul. The primary role there, I was the primary health worker in emergency response for about 150 personnel and air traffic controllers on the base. So I was the clinical lead for our little health centre we had there. Again, utilising a lot of the skills that you kind of master in Ivanhoe and Broken Hill and the remote sites out here. Also, while there, I was on one of the trauma teams in the military hospital, so quite regularly they'd have mass casualty situations where there might have been a bombing or a shooting, and you really get to go in, and we wouldn't only help the NATO forces, we would help a lot of the local military as well. So again, that was an amazing experience to be able to help what is a pretty war-torn country at the moment, and exposure to a very different type of trauma that thankfully we don't generally experience in Australia, which was quite eye-opening and really makes you appreciate what we've got back here. after finishing my second rotation, I took a position back in Broken Hill. That was only at the start of this year. I couldn't beat it. I really enjoyed it, my time out here, and it was such a social place. For my first 3 years I spent here, I lived in the nursing quarters here for quite a long period, and you get to make your own little family out here. Chelsea, who's up next, I believe, I got to know her pretty well, and Pip as well when she was out here, and you really do make a little family when you're out here. It is a long way from home, but you get your own little cliques, which is really good, and get to meet and learn a lot of things out here, so that was really great. With the opportunities that you do get out here, they're just experiences and doors open that you'd never be able to get on the coast. Been quite fortunate, Pip mentioned before, I've just accepted a new role which will be part of the critical care outreach team, to be able to provide a bit of a higher level of support through the juniors coming through the hospital and with the critical patients that might be deteriorating on the ward. So yeah, it is really good what working out west does have to offer if you are happy to give it a red hot crack.
Fantastic. Thanks, Mitch. That was great. We've got a few questions. The first one is from Amy. So she's asking, is rural nursing more challenging in regard to less support and more pressure than working in a major city from your experience?
I think they both provide challenges. When I was out here, I've been very fortunate the whole time. There has been support there whenever I've needed it. I don't think I've ever been pushed into an unsafe situation. But at the same time, they do give you a lot of opportunities to step up if you are feeling comfortable. Through, as I mentioned before, so by the end of my new graduate year, because it is quite a small hospital in that regard, a lot of the time we'll only offer emergency or some limited emergency operations over the Christmas period. We'll shut down all our elective operations. So the surgical ward kind of slowly grinds to a halt almost. And they kind of took that opportunity to give me the opportunity to step up, I guess. So by the end of my new grad year, I was doing in-charge shifts, which you definitely wouldn't be doing on the coast. But as I said, there was always that support there if you needed it. In the larger kind of metro hospitals, I think, yeah, there's challenges wherever you work. So there's a lot more acute patients or regular acute patients you'll receive in metropolitan areas. So I guess there's good opportunities wherever you go, and I really enjoyed what they've been able to offer out here.
Fantastic. Thanks, Mitch. Okay, we now have a question from Simone. So for those who have come from bigger regional areas or metropolitan areas, how did you cope with the change to rural and remote areas which had less resources available at your fingertips? So in regard to specialists being far away, sort of less specialty areas, front-hand review, and, especially when you're in Ivanhoe, how was that? Did you find it frustrating, or tell us a little bit about what you thought?
I guess it can be frustrating at times not having everything at the tip of your finger, which would be the ideal world. But it does make you think a little bit outside of the square. So you always do make it work. Thankfully, the RFDS are kind of the backbone of the community out here and are always there when we need them. So if there was a critical patient, we had the ability to fly them to Broken Hill or to Dubbo or Adelaide as we needed to. They also offer a lot of community support. So they've got mental health teams, Aboriginal health workers, a lot of specialists that do come out on a regular basis to the remote areas. Although you might not be able to get patients in to see them as quickly as you might be able to in larger facilities, they are still available. And because it is such a small community, people are quite often happy to kind of step aside and let someone else step in if they need to. So there's always options available to get people to definitive care, whatever that may be.
Cool. Thanks, Mitch. This one I'll ask, but if, Chelsea might have an answer here too. So the question is the Broken Hill New Grad program competitive? Like, in a sense, is there limited spots, and do a lot of people apply? From your experience anyway, Mitch.
I can tell you about, so 2015 was when I moved out here for my new grad program. Chelsea might be able to fill in any changes possibly since then. When I applied out here, I also looked at applying in Coffs Harbour. Coffs Harbour was very competitive. I know they had over 200 applicants for Coffs Harbour and maybe 20 positions. And out here for that year, there was about 45 applicants and 15 positions. So as far as the ratio is concerned, it's definitely in your favour to head west. And yeah, depending on where you like to go, I guess. But Chelsea might be able to fill in a bit more if that's changed since then.
I can fill you in on information for 2021. The grad start applications open in the next month or so, I believe, and we're taking 32 new grad positions for next year. And I know last year we also took 32 new grads, and I think we had about between 50 and 60 apply. So, you know, we have increased it in the last few years, which has been great, and we've gotten more new grads staying into their second and third years now, which is really great as well. Happy to, Pip can pass on my contact details at the end. I'm heavily involved with the grad start for next year, so happy to take questions later if that's helpful.
Yeah, definitely. We can, we'll redirect you all to a digital venue after the webinar, and we can share all the contact details there. So I'll make sure you all have that. Okay, so one more question, I think, then we'll go on to Chels. So Steph has a question here that she's gained entry into a postgrad humanitarian health degree and then will finish her last 2 RN subjects, thinking about mercy ships. Do you have anything that you could add to that, Mitch? Do you think it, you know, exciting based on your adventures, something you'd, you know, back or support?
So I've looked into mercy ships a little bit in the past. I've had a couple of friends who regularly go and assist on the mercy ships. As far as what you're able to give back, I think it is an amazing opportunity, and you do get to do some pretty amazing work for people who are rather vulnerable and wouldn't normally have that level of care. As for going about it, I've never quite got to that step. So on the finer details, unfortunately wouldn't be much help. But yeah, it does look like an amazing program that they do offer around the world.
Cool, thanks. I think Leonie mentioned she had a little bit of input here in regard to a question. Leonie, did you just want to answer that one in regard to Amy's question?
Sorry. Yeah, that was just, I was just adding to what Mitch said earlier about, where is it? I've answered it and now I've forgotten it. Sorry, I'll just have a quick look. Yeah, so I said to Amy that, because she was saying, oh, where is it? Oh, is rural nursing more challenging, e.g. less support and more pressure than working in major cities? And I said it can be, but you learn to thrive on that, and the challenge only improves your skills. So, yeah, so if you're that kind of person that's enjoying the rural, you know, the rural scene as far as nursing goes, it just builds your skills and your resilience and your character, which is obviously what it's done with Mitch, definitely.
Yeah, fantastic. Okay, well, I think we'll leave it there for now with Mitch and move on to Chels. So just make sure I can change my page. Okay, so Chelsea is the clinical midwifery consultant for Far West Local Health District. Chelsea is based in Broken Hill and provides midwifery expertise, support, education, governance and service planning to the district, all the way from Tibooburra to Balranald, from Broken Hill to Wilcannia and everywhere in between. Chelsea grew up on a sheep station and attended school in Broken Hill and studied her undergraduate degree via correspondence before becoming a midwife. Having a love for rural midwifery, Chelsea has taken on an active role in the establishment of the Broken Hill Midwifery Group Practice, team leader and maternity unit manager roles prior to becoming the clinical midwifery consultant. Chelsea is exceptionally passionate about rural health and ensuring all women have access to safe, quality care regardless of where they live. Thanks, Chels.
Thanks, Pip, and thank you for inviting me along tonight. I definitely feel like my story is a mashup of Maisha's, Mitch's and Leonie's. So hopefully you get something new out of this one. As Pip mentioned, I am a Broken Hill local. I grew up on a sheep station just outside of town, and I attended school and high school in Broken Hill. I always knew I wanted to be a midwife, but I wasn't quite sure how to get there. I knew from an early age, I don't know how I knew this, I'm from a family of teachers, so there's no nurses or midwives in my family at the time, but I knew I wanted to work as a midwife and not necessarily as a nurse. So when I finished school, I started a medical science degree. I worked as a dental assistant for a while until I, just by accident, one night came across the Bachelor of Midwifery degree through UniSA in Adelaide, and it was quite new at that time. So I thought, oh great, I'm going to be a midwife. So I enrolled in that. I had been working as a dental assistant with the health service, but then I moved to working in the pathology lab at the local hospital. And I started studying my Bachelor of Midwifery, which is a 3-year degree, very similar to the nursing degree. And I did it over 4 years while I was working full time. So then in my final year of the degree, I was very fortunate enough to get an assistant in midwifery role. And I actually worked pretty much full-time hours in that 3rd year, and then studied full-time as well in that 3rd year. Again, being Broken Hill, you get to know people outside of work. So I did get to know the executive director of nursing midwifery at the local football club. And when she found out that I was studying to be a midwife, she thought, well, how are you working in the pathology lab? So we applied to all the right people, and we got some funding to put me on as a AIM, which I think is the grassroots and an amazing place to start as a midwife. I learnt more in that 3rd year than what I did, I think, in the whole degree by working as an AIM. So if that opportunity comes to you, please take it up. I highly recommend that. When I finished my degree, I was fortunate enough to do my new graduate degree in Broken Hill, because that was my plan. I didn't have any other plans to go anywhere else. I really love living in Broken Hill. And very similar to Mitch, by the end of my new grad year, I was doing in-charge shifts. Sometimes, I think there was a few of us new grads that year, and I have this vision of memory of 2 of us doing 4 night shifts together, just 2 new grads kicking back in the maternity ward and running the place. And I just think that we wouldn't do that anymore. Our model of change has changed a little, but I think that was the start of my, if you get offered an opportunity to do something, just say yes, and then think about it later. But it was a very supportive environment. My managers were very supportive of myself and my colleagues. And we always had safe structures around us. We always had an escalation plan. Like Mitch said, you never felt like you were alone, even if nobody else was around. There was always lots of things in place, people to call, processes to follow, which just gave you that little bit of encouragement to, take a step into that in-charge role at an earlier stage than what you might get to do anywhere else. So then into my 3rd year, I think it was, the maternity unit manager was going on holidays, and she offered me a chance to act in her role for a few weeks. My first thought was, why would I want to do that? That sounds frightening and terrifying. But I said yes, and my theory was if I sucked at it or if I hated it, then I didn't have to do it again. So around the same time, I got my clinical midwifery specialist personal grading, and then it was all systems go from then pretty much. I had a crack at the acting team leader role, which was a CMS2 job, as well as the unit manager role. And in that same time, in that sort of 18 months or so, we also established a midwifery group practice. So for those who are aspiring midwives or have anything to do with midwifery, a group practice is where we offer a continuity of care model. So a woman and a family get the same midwife throughout their pregnancy, during labour and birth, and then up to 6 weeks postnatal. It's a really great program. We do accept new graduates. So if there is any 3rd year midwifery students who are looking to apply for grad start and want to work in an MGP model, please put Broken Hill in as one of your preferences. We really love our student and our new grad midwives, and we're a very young, dynamic group. There's only a couple of the midwives who are older than 45, so we're quite a young group, and it's quite nice to be around as well. So we had a really good active role in establishing that group practice, which turns 5 this year, so that's very exciting. I then got the opportunity to have a go at working in the MGP. We've got 2 teams, so we have core midwives who work 12-hour shifts, and they work solo on the ward and they care for all the inpatients. And then we've got the group practice who work in the community and then come in and out when the women are in labour. I was never a huge fan of being on call, as much as I love the concept of midwifery group practice, and it is definitely the gold standard of maternity care. After being on call for 4 years as a student midwife, I needed a break from being on call. So I chose to work in the core, and I loved it. I loved working 12-hour shifts. I loved being in charge of the shift. I loved even being on night shift with women. If a woman is going to struggle and need help and breastfeeding support in those first couple of nights, it's the core midwife that's providing that support. And then they go home and they get cared for by the midwife and the child and family health nurses. So I did get to have a go at being in the midwifery group practice for 6 months, which was great. And it's, you know, as a few people have said, when you work rurally, you do look after your friends and people you went to school with. And as long as you've got processes in place to make sure that all the I's are dotted and the T's are crossed, then it can still be a really safe place and a really enjoyable place to work as well. So then, just on 3 years ago now, the opportunity to work as the CMC came up. And like most people, when you're on the ward, I kind of thought, what does a CMC do? I didn't really see much of our CMC beforehand. She worked part-time, and so it was a completely different area. And so I resisted for a little while until I actually got to chat and hear what a CMC does. And the moment they sort of said, you can have, well, I'd still describe it as influence without authority. So I still get to have a say and get to find out all the latest and greatest and get to, you know, suggest what I really think would be really great to happen, but I don't have that logistical operational manager responsibilities either that comes with a unit manager. So having a go at acting in the mum role taught me what I do and what I don't like about leadership and management, which was great to learn at an early stage in my career. And then being in the CMC role, getting links with the leaders across the state, other maternity unit managers and leaders across all the different LHDs. I have a lot to do with the CMCs out in Western New South Wales LHD, as well as lots in Sydney and at the ministry as well. So that's been really interesting, and I think it's just really great that your executive and the other managers around you in a small LHD like Far West, they trust you and they believe that you'll do a good job. You'll get opportunities to try things that you never really got to do. At the moment, I'm having my very first go at acting in a nurse manager role, which includes running a COVID-19 drive-through clinic. So if you had said that, you know, does being a midwife without a nursing degree stop you from doing things? The answer is no, absolutely not. You've got plenty of other nurses and other midwives and managers with different expertise around you. Nurses have their own specialties as well, just like midwives do. So I would suggest that if you feel like you're getting pushback from other places and feeling like you're hitting the glass ceiling, that there's always a way around it as well. A couple of years ago, I had a month or so working over in Tanzania in Africa, which the most thing that taught me was that we have nothing to complain about in Australia. Even coming from rural and remote areas, there are some similarities between here in Africa, but at the end of the day, most of the issues that we find, it's a lot easier for us to fix. We've got the governance and we've got the structures and we've got the leadership in our country to be able to, you know, improve services a bit easier than what some other places do. Otherwise, Pip, if there's anything else you'd like me to cover, please let me know.
No, I think that's great. That's been very, very informative. I have a question actually. in this role I'm in currently, I've had a number of people ask me, and you sort of touched on this, but midwives who enter their study as a direct entry midwife, are they disadvantaged in rural areas? For example, I know that they can often get jobs in regional sectors, but are they going to be disadvantaged in the smaller or even medium-sized rural centres?
I think in my experience, and every state is different, New South Wales are a little bit ahead of places like South Australia, where a couple of years ago, if you've got a birthing facility, then you need midwives. It's different if you're in a non-birthing facility like Ivanhoe. So, I mean, it would be very difficult for me to get a job in Ivanhoe, but in my job at the moment, that's how I met Pip in Ivanhoe. So you do get to visit the non-birthing sites and provide care and experience there. But in my experience, and I can vouch for Broken Hill, over 50% of our nurses are 50% of our midwives are single registered. So there are very few dually registered midwives who maintain recency of practice in nursing. What we have found is that midwives who enter midwifery nurses and midwives who enter midwifery often stay in midwifery if they're going to stay for the long term. And the opposite's true. They often find it's quite difficult to maintain their nursing registration. So in Broken Hill, I can fully vouch that single registered midwives are very welcome, and our maternity unit is a midwifery unit. We don't care for gynae patients or paediatric patients. We do have scope to help out in those areas as an AIN/EN scope of practice. So, I mean, I can still go and help out in other wards. I can still run a COVID-19 clinic. I can still manage other nurses in a nurse/midwife role, manager's role. But no, so far it hasn't stopped me from being able to do anything.
Yeah, that's really good to know. So, yeah, fantastic. Okay, so I've been sent through a question here. So, what do you think the characteristics are that make a good or a successful rural nurse or midwife?
I think being flexible and having a can-do attitude. It's probably got me into more trouble than not, actually, just being a yes person, just saying yes and then thinking about, do I have capacity to do something later? But I think having an optimistic outlook, but still being quite calm and sensible, and just knowing that as long as you know what your escalation plan is and how to call for help, one person can't do it alone. Even in places like Ivanhoe, you've still got one or two other people, and then you've got external stakeholders who can come and help you if you really got into trouble. So I think just trying to keep, the characteristics of being flexible, of being calm under pressure, as well as being optimistic and just keeping it in perspective, I think is quite important. We still live in New South Wales, we still live in Australia, we still have internet, and we still have planes and things like that. So we're not really isolated, even if we are alone.
Fantastic. No, I think that's very true. Okay, so I have a question here from Carol. As a mature age student wanting to work in rural and remote, how do I do this if I can't get a new grad?
I think as long as wherever you are lucky enough to get a position, as long as you've got development and support plans in place, as you might have picked up, I was a very junior clinical midwife consultant when I started, and my managers had in place for me a development plan and a professional development, mentoring type program. It was kind of like the new grad of the CMC world, I guess. There are more than one ways to get a new grad year. I mean, the Grad Start program hasn't been around forever. There was first year out nurses getting jobs well before the Grad Start program started. So I think if you are going to either work in private practice or work in a rural and remote setting, if you're going through the mainstream way and not through the Grad Start program, I think as long as you can have some type of clinical supervision set up, or a mentoring program, or someone to guide you along the way when you do need to, chat about things.
Fantastic. Okay, so I'm going to open up questions to everyone now. So if anyone else thinks they can have a go at answering, feel free to all panelists to jump in. So This is a question from Judith. Is it sometimes frustrating if the nurse or midwife is unable to provide safe and quality care to rural patients due to lack of funding? And how do you respond to this?
I can have a go at having a little response to this one. I think when you live rural and remotely, you need to have clear expectations about what you can and can't do. I think you need to be aware of the clinical capabilities of the place that you're working in. And I think you need to be aware of the community that you live in and what they need as well. So it's not always about what I want and what I want for my women or my families that I'm looking after. It may be that you know, the woman or the family that I'm looking after may not want to go to Adelaide and get the, you know, the tertiary care obstetric level, you know, that they may be, you know, there might be a lot of other things going on. So I guess in regards to funding, like Mitch said, you can't have everything all the time in all the places. And I think you've just got to be aware of where you live and what the clinical capabilities are for the place that you live in. You know, I would love to be able to keep all 32-weeker babies that are born too early in a NICU in the middle of far west LHD, but we know that we can't, and we know the safer place for them is elsewhere.
Yeah, very, very good response. Okay, so Joelle's asked a question here. We touched on this a little bit last week, but it'd be interesting to hear your thoughts on this, Chels. So do you know if interviews for new grad positions will be held on site or whether they may be online due to COVID-19?
Yeah, I'm 99.999% sure most of them will be online this year. A lot of the places are talking about using the PEXIP platform, which is, if you can access Google Chrome, you can access PEXIP. I know in Far West and I think Western, definitely for midwives and most probably for nurses as well, they'll be using the PEXIP platform, which is a very nice, easy to use video conferencing program, which is nicer than the phone interviews and what you get at some places anyway.
Yeah, fantastic. And Joelle, if you go onto the digital platform that you'll be redirected to on the thank you email from this, you'll see last week's recording, and it goes into some interview skills on how to undertake an interview online and how to adjust and make sure you're hitting the mark there. So I think that might be helpful for you. Okay, so Denise has a question here. I have always dreamed of going rural. However, I have 3 young children. Just wondering what the community life is like in Broken Hill. Is it family friendly, for instance? So fire away, Broken Hill friends.
You can start this one, Mitch.
Yeah, okay. So I don't have any kids, but for the community side of things, Broken Hill, as I said, you make your own little family out here. It is a very community-centric town. It's very, what's the way to do it? They find a way to come together in all of the difficulties that are thrown at them. So they really jump on the back of sport and anything that they can out here to bring everyone together, which I've found great. They do have a lot of good schools out here. My partner, who's sitting behind staring at me, she's actually a high school teacher in town here, so I have to say that. But no, from everything I've seen, it is quite a good little town to raise children in. Pretty good values out here. Chelsea, being a somewhat local, might have some more advice to throw in on that as well.
Definitely agree with what Mitch just said. I think particularly as nurses and teachers, a lot of transient families that come to town, and they really are embraced, particularly if you can get into some type of sport or some type of out of work hobby. If you are living and working with the people that you work with, it's sometimes nice to get out of that environment sometimes. I know Pip made a lot of friends with my friends and vice versa. So I think if you're willing to be brave enough to come out here and settle in the town, you will be embraced for sure.
Fantastic. Leonie, you might be able to add a little bit here, having kids yourself, and extend that to other areas, rural, regional and remote.
Yes, it takes a community to raise a child, and there's nothing better than a rural community to raise a child. It's safe no matter, it's a lot safer per capita, I suppose, because you're in a quite a rural sort of environment. Everyone's looking out for your kids to a certain extent. There's great art opportunities for kids and adults, and social activities. Sporting, as the guys said, are just amazing. All sorts of sport, footballs, netball, basketball, motorbike riding, open spaces, horse riding, gymkhanas, all sorts of things. It's a fabulous place, and often, as probably Mitch will comment on here, you come out to a rural community expecting to spend a certain amount of time, and it gets under your skin. We see it with lots of teachers and nurses alike. They come for their short amount of time and then they stay for the rest of their lives. They bring up their families and become part of the community. So, yeah, couldn't speak more highly.
I have to agree with Leonie on that one. I moved here for 1 year, and that was in 2015, and still here.
Yeah.
My mum came to Broken Hill for 6 months and was here for 30 years.
Yeah.
Steals your heart. Okay, so we will finish up in a minute, but I just want to address a question here, sort of in regard to the multidisciplinary team and in regard to how much allied health support do you have in rural and remote areas?
I can answer that one. Not only with COVID, but even prior to COVID, we had a lot of virtual services. If dietitians and physiotherapists, occupational therapists didn't outreach to the smallest of communities, then there is a virtual service offered. So that's from my point of view in central New South Wales. I'm sure it'd be similar from Broken Hill.
Yeah, similar again. So even in Ivanhoe, as far as physios and the like, we would have a physio there for 1 day a month, which in a town of 90 is a pretty good achievement, I feel. And if there were any shortfalls, a lot of the time back then we didn't have the facility to do video like teleconferences as we do now, but we still did have their phone support if we needed to, so we could still get advice to implement things to get through until they're in town next, but still reasonably frequent considering the remoteness.
Fantastic. Yeah, I totally agree with that. Okay, so I'm going to just hand over to Chris, who has a question for you guys.
Thanks, Pip. Thanks for bringing me in again. Yeah, quick question about career progression. So do you think by having a career in a rural setting, do you think that has held any of your careers back, or do you think it's been an advantage for you all?
I'm happy to take this one first if you like. I think if you are committed to making rural your environment that you were planning on working in for a year, the skills that you would gain in those first few years, like Mitch touched on, you may not get anywhere else. I'm 8-ish years out now, and I'm sure I would not be in this position if I was in a tertiary centre. Obviously the skills and the exposures that you get in a tertiary centre are also very different to the things that you get in the rural team as well. So I think they're very different, and I think they both have amazing perks as well as, you know, and benefits and things like that as well. But in regards to has it held me back, I don't think so, not in the slightest. I am committed to staying rurally, and I guess if I did want to move to a tertiary area, then I would have to learn all the bits and bobs that happen in that environment as well.
Definitely hasn't held me back. I like Chelsea. I've taken every opportunity that's been thrown at me and ask questions later, and I'll kind of paddle like a duck underwater and try and remain calm on the top. But yeah, definitely hasn't held me back. I think maybe if you're that flexible person that is and dedicated to looking after your community, then you have more opportunity in a less populated area to rise to the top maybe. because I think probably metropolitan populations sort of might be a little bit more competitive, more people looking for that opportunity. I don't know. But anyway, it certainly hasn't held me back. I've been very, very lucky.
Yeah, I totally agree. In the time that I worked out in Dubbo and Burkenbury, I just in that short time I was doing so much that I wouldn't have been doing if I was working back on the coast in COFs. I had a lot more responsibility, but I also had a lot of support, and like help was only either a phone call away, like video, like link up away. Like there was never a time where I felt unsafe. It was very supported. And also, like, you're working very closely with the doctors that do work there. So for me, like, a lot of them knew that I had like specific interests in some areas. So they'd say, oh, Maisha, like, do you want to come have a look at this colposcopy with me? And I'm like, yeah, I don't really know what I'm looking at, but cool. Like, you know, so everyone like, you develop a really good relationship with like the whole allied health team. So you pick up skills elsewhere and like different things you learn about and stuff like that. So yeah, definitely didn't hold me back whatsoever. I think it helped excel my career, I'd say.
Thank you. Thanks so much. Hey, Mitch, before you answer, you talked about emergency and getting and working in Ivanhoe, sort of no doctors around. Is that scary as well? And how do you cope with that? Or what type of person manages that?
It certainly was a little bit out of my comfort zone when I first went down there. I'd only been a nurse for 5 months at that stage, so obviously very much in the deep end. I was quite fortunate. The health service manager down there was an amazing nurse who's now a nurse practitioner, and was very supportive on that. Learnt a massive amount. As I touched on before, and as Leonie mentioned, they really tend to throw a lot of education at you as well. So I was quite fortunate to pick up a lot of skills while I was out there. But yeah, definitely times it was nerve-wracking when there's only yourself and one other nurse managing a motor vehicle accident or whatever it may be. But at the end of the day, as we mentioned, the RFDS are a phone call away. There's always help there when you need it. And you really do learn on the run, essentially. So no, it was really good.
Thank you.
As we were talking about a moment ago, as for career progression, I certainly think I've been very fortunate to, I guess, get to where I am, only being 5 or 6 years out, and don't feel I would have achieved anything near this amount if I was on the coast, or be able to provide for the community like you can do out here back on the coast. So it's good.
Thank you. Brilliant. Thanks, everyone.
Yeah, thanks, guys. That's amazing. Okay, so I think we'll wrap up now. I think we've had a good dose of questions. What I will let you all know is that we're going to share a quick survey. We'll pop it in the chat function now. If you don't have time, that's okay. We're going to send an email to all of you tomorrow, and just a thank you, and also a reminder just to sign up for the next few sessions. Next week is all about life as a rural and remote new grad. So all the questions I'm sure many of our third-year students are wanting to ask. And it will also redirect you to our digital platform, Rural Health Pro, and it may prompt you to sign up. That won't take a moment. And then in that site, you'll have access to the recording. So if you missed last week's, you'll be able to see all about the application process, interviews, how to address selection criteria, everything you need to know. It was really fantastic. And then, of course, you'll be able to review tonight and make sure you are well and truly around rural and remote health and all the career progressions you can take and opportunities you can take advantage of if you wish to trial rural and remote health. So I'd really like to thank all of our speakers. I thank you all for coming, and it's been a really great evening. So see you all next week.